Hello, everyone. My name is Ivory Allison, and I am the National Director of Community Impact here at the American Liver Foundation. And I'd like to be the first to thank you for joining us for our first Life of Biliary Atresia and Beyond series for 2023. I would like to introduce you to our new program coordinator, Casey Pender, who joined us a few weeks ago and one of our Biliary Atresia Facebook moderators. And welcome any of our Biliary Atresia committee members. I'm excited to share that today we are joined by Dr. Jaime Chu, who will be presenting on emerging therapies in biliary atresia and other pediatric cholestatic diseases. But before we get started, I'd like to quickly go over a few reminders. Today's Life with Biliary Atresia and Beyond series is being delivered on Zoom and will be recorded. We'd really appreciate it if you could mute yourself during the program to avoid any disruptions while our speaker presents today. If you do have something you want to share or have a question, please utilize the Zoom chat feature or raise your hand and share your thoughts that way. Again, please note that this program is being recorded and will be shared in ALF's private Life of Biliary Atresia and Beyond Facebook group for folks who might not be able to join us live, and our YouTube channel. So if you would like to keep your camera off, please turn it off now. I'd also like to take a moment to acknowledge our generous sponsor, Albireo, for their support of the American Liver Foundation's Biliary Atresia initiative. We are so grateful for their ongoing support of this program. And now I will introduce our featured speaker. Dr. Jaime Chu is the Mount Sinai Endowed Professor in Pediatric Liver Research, Medical Director of Pediatric Liver Transplantation, and Associate Chief of the Division of Pediatric Hepatology at the Mount Sinai Kravis Children's Hospital and the Recanati Transplantation Institute at Mount Sinai. She received her BA from Harvard University and her MD from New York University School of Medicine. She completed her general pediatrics residency training at Northwestern University Children's Memorial Hospital, now Lurie Children's Hospital of Chicago, and her fellowship in pediatric gastroenterology, hepatology, and nutrition, both at Children's Memorial Hospital and at the Mount Sinai School of Medicine. Dr. Chu is a physician scientist in pediatric hepatology. She leads an NIH-funded scientific research group that examines the pathways involved in pediatric liver development and disease. Dr. Chu's clinical research includes participating in clinical trials in genetic cholestatic diseases, pediatric acute liver failure, and viral hepatitis. She also serves as the sole pediatric hepatologist on the AASLD COVID-19 Task Force, which is a national committee that gives guidance surrounding COVID in pediatric and adult patients with liver disease and liver transplantation. Dr. Chu, thank you for giving us your time today. I'll now hand things over to you.
Okay, well, thank you all for taking some time out of your evenings or afternoons to sign on with us today. I am going to share my screen, but I also just want to give acknowledgement and gratitude to the American Liver Foundation for everything they do. For those of you who are potentially new to the ALF, it is a really wonderful foundation that really prioritizes patients and families. And I know in the New York area where I'm calling in from, we have annual liver walks, which are really a fun and great place for patients, practitioners, healthcare workers, and everybody to kind of get together in a fun social event and raise money for liver research. So let me share my screen. Okay. All right, so please feel free to raise your hand during the time, interrupt anything that you find helpful. The plan for tonight is I'm going to talk for about 20 minutes and leave a lot of time for question and answer. just in case you have questions that are not related to this topic, it's free for all, whatever you want to ask, I'm happy to try and answer. So as Casey mentioned, today I'm going to talk to you about emerging therapies in biliary atresia and other cholestatic diseases. Okay, so for probably all of the families here on the call, you know that biliary atresia is a rapidly progressive disease and the most common indication that we do liver transplant for children. And why, all of you have probably experienced the rush of diagnosis and treatment, rushing your baby to the operating room is really because if you do not treat biliary atresia, 100% of these babies will have end-stage liver disease by a year of age and near 100% mortality, 100% chance of death by 2 years of age, if you just let the process go. So, the tricky part about this disease for so many hepatologists and GI doctors is that, babies around 1 to 2 months of age look pretty healthy. The pediatricians may not really pick up on it, but, maybe they say, oh, that's weird. This is my first baby, but the stools or the poops are a little bit white colored. But really, this is a picture of one of our patients that actually had a Kasai, but at 8 months of age, this is what end-stage liver disease looks like. So all of you know that really timely diagnosis of biliary atresia is critical to the outcome and survival. So this is a cartoon of what a normal liver looks like. And in biliary atresia, there is a inflammation and scarring of the bile ducts that really happens from outside the liver and creeps into the liver. And the treatment for biliary atresia is a surgery called a Kasai portoenterostomy. And I'll refer to this as just a Kasai going forward. But what the surgeon does is that they take all of these scarred bile ducts, and ideally you catch it earlier, and then they hook up a loop of intestine to save the healthy part of the liver and have that drain the bile. And what we call a successful Kasai is one where the bile drains, and we use that as how we tell that is by the bilirubin levels after the surgery. I'm presenting some percentages, and this is from a paper in 2003, 20 years ago, but yet these numbers are still the same. And that's a problem in our field. And so really what you see here on the left is the baby's age, so in days. So if you're less than 60 days, then there is a 70 to 80% chance that the Kasai will be effective and will drain that bile. But each and every month that you wait longer, not you, the family, but that it doesn't get picked up or the baby doesn't make it to Kasai, these numbers exponentially decrease. Where if you are over 4 months of age and, there are some babies that, they've gotten missed really, and they come to a liver center and they're 5 months old, the chance of success is 10%. So in some cases, we don't even offer a Kasai as the actual option because there's such a the risks of taking the baby to surgery is much higher than the chance of success. So the average age of Kasai worldwide, okay, in the United States is 63 days. So let me just go back one more slide to say that 63 is after our most ideal outcomes, right? So in the United States, our average is still diagnosing babies at 63 days and getting them to Kasai. And 44% of these patients have Kasai after 60 days. In Europe, this is also around 60, and in Canada, the same. Late diagnosis remains a problem worldwide. Why is that? It's because, like I showed you, babies with biliary atresia actually don't look so sick. And really, babies that are breastfed, babies that are Asian, things like that, like regular normal causes of jaundice, physicians may assume that it's that, and then they get missed. But what we know is that when you can diagnose the baby with biliary atresia early, that this certainly can improve outcomes. And there was a study that looked at if every baby with biliary atresia had a Kasai by day 46, so we're not talking about 60, but we're talking about 46, you could actually avoid 5% of all transplants in children per year. So this is to say that early diagnosis and early surgical treatment is so key. And we know this. This is not new to us. Like I showed you, those numbers are 20 years old. So if we know that, why can't we move the needle down to get to that 46 days of diagnosis and treatment instead of the 63 in the United States? This was in the United States. You know, we all know that there's many different medical centers, lots of different liver centers, which is so great. But when there's centralized medicine in a country like France, they're able to track, and they have a national registry of all the biliary atresia patients. So they looked over decades and said, what is our average age when we can get the babies to Kasai? And if you can see, this still hovers around 60. So they're looking on decades. And really, we've known this for 50 years, that biliary atresia is our most common reason why we transplant patients. So what are the barriers? Why can't we be better? And this is kind of what I wanted to show you today. So what do we know? So certainly the liver field, this is our priority. We know that this is a problem. And so this is what we know right now that contributes to positive or negative outcomes in biliary atresia. We know that by age 2, 50% of babies will need a liver transplant with BA. So a lot of what you'll see, and we'll talk about clinical trials and we'll talk about outcomes, but survival with native liver means this child still has its own liver, right? So he or she did not need to get a liver transplant. But we know that by 2 years of age, 50% of children will need a liver transplant. And by 20 years of age, probably 80% of children will need a liver transplant. And so what do we know that are positive factors and what are negatives? So what are the positive factors that kind of push your child to the 20-year age where they have not needed a transplant? You know, we've highlighted already early Kasai. First and foremost, you need an early Kasai. Biliary atresia is a spectrum of disease. So when it says isolated biliary atresia, those patients tend to do better than patients with syndromes where there are other congenital abnormalities that are associated with the biliary atresia. And fibrosis or scarring of the liver is really one of the drivers that says, is this liver healthy or is it not? And are you going to see progression? Things like fluid in the belly called ascites, poor growth, or any heart issues, you know, those things can push outcomes to not be as great. And here, the negative factors are late age at Kasai. Again, I mentioned where there's other associated congenital anomalies we call syndromic biliary atresia. CMV is a virus that I'll tell you more about, and that may predispose to worse outcomes and again, more fibrosis. You know, I think that as a parent, you want to know, you know, what do we know about the long-term outcomes of patients with biliary atresia? So I just kind of showed really transplant as the main outcome, but there's so much more than just transplant, right? So most of the complications that we look at, you know, that would bring a child to transplant, with a child with biliary atresia to transplant, and any child actually with liver disease, is in biliary atresia, cirrhosis or advanced liver disease will be a cause of why children will need to go to transplant. Varices, which are from the high stiffness of the scar tissue in the liver, sometimes you can have GI bleeding, and that's called, it creates esophageal varices. And infection. So if the bile is not draining that well, it can get infected. And so we call that cholangitis or infection of the bile duct system. And there's a very small but real chance of malignancy when you have something like cirrhosis. So that certainly will bring a child to transplant. But I wanted to present also this slide, which is, you know, what about other things? What about from the day-to-day that parents are most concerned about, like growth, bone health, neurodevelopment, and quality of life? So this was a great slide. And again, this is going to be recorded, but I'm happy to go back to the slide in the Q&A section. But this is a great review that looked at a lot of different long-term papers. And when I say a lot, we don't have that much long-term data, but they broke it up into infancy, childhood, and adulthood. And they looked at each of these and kind of said, how does growth, bone health, neurodevelopment, health-related quality of life, how does that, compare to when patients have biliary atresia that have not undergone transplant? So these are biliary atresia patients with their native liver. And infancy, prior to clearance of jaundice, meaning their bilirubins are still high, we know that the height and weight gain are impaired. But when the jaundice is cleared in childhood, actually growth is good, and the majority reach normal adult height and weight. Okay, so for surveillance and care, what does that mean? That means we always look at growth. We make sure that the growth is good in children. That's probably what we care about most, really. Bone health. So when you have jaundice and the bile is not moving, then you are at increased risk for bad bones, rickets, and fractures. So we follow vitamin D a bunch, and this is easy to follow, easy to supplement. So that's something that we regularly follow. For neurodevelopment, in infancy, there is a slight deviation from norms. But what we have here is that in their North American population, the studies so far showed that in childhood, children with biliary atresia are actually comparable to normal kids without biliary atresia. There are some European studies that suggest that there was impaired IQ and impaired motor skills in children with BA versus not. But in adulthood, in the studies that we have, there was no difference in education or employment. So that's good to know, right? But as physicians, we need to get them to that point. And in terms of health-related quality of life, which is actually a very formalized measure, that certainly, and I'm sure all of you can attest, that parents experience elevated stress when their baby is going through diagnosis and surgery for biliary atresia. And there's actually been quite a few studies in, probably 6 different countries in Europe and Asia that shows that the quality of life doesn't differ from healthy controls or liver transplant patients. We did have a study from in North America that did show that there was decreased quality of life compared to children without biliary atresia. But then again, in the European studies for adulthood that we have, quality of life seems to be comparable. But really, this highlights the fact that psychosocial support is really so important for any family with liver disease, but also specifically biliary atresia. Okay, so, families with biliary atresia are, well educated. They're reading about all of this. Clearly, you guys are signed on to here. What I thought we would focus on is really what are the gaps in knowledge and treatment for biliary atresia? How do we get a better understanding of what's causing biliary atresia? Are there markers to diagnose these babies earlier? But what we really need is a better understanding of why biliary atresia progresses and therapies to stop the progression of disease. So just one slide on understanding of what biliary atresia, because I really wanted to focus on kind of what the new drugs and therapies on the pipeline are. But what causes biliary atresia? And the question that we're really working on right now is, does the disease start before birth or does it start after birth? And so here's birth, right? And there are a lot of factors that we are looking at as a field in terms of genetics, in terms of viral infections, toxins, and both before birth and after. And what makes one baby who's susceptible to this more susceptible to biliary atresia, and then while another one has the same virus exposure or toxin exposure and doesn't get biliary atresia. And then also kind of what are the outcomes? Why do some babies do well in Kasai's and some do not? Okay, so what I wanted to really kind of focus on are early markers, better understanding of why this progresses, and therapies to stop progression. And the focus is really to say, can we determine which babies with biliary atresia will progress to need liver transplant, or which are those babies that won't need liver transplant? And that way we can help educate families and kind of give them some sort of prognosis. And really what's emerged in the last couple of years, specifically really in the last, I would say 2 years, is this focus on bile acids. Okay, so we're going to talk about bile acids, but at a very basic level, but feel free to ask questions or interrupt. So bile acids are just the components of the bile or the bilirubin that we measure in the blood, right? And that's what babies present with in terms of jaundice. So our most recent study that was just published last year took children that had biliary atresia and were 6 months after Kasai, okay? And these babies, we wanted to look at actually specifically were babies that had normal bilirubin. So babies with biliary atresia had their Kasai and then normal bilirubin at 6 months. Okay, so these are the kids that probably are, as physicians, we would say, yeah, your baby's doing great, okay? And what we found is when we measure bile acids, and I know we have a couple of Mount Sinai patients on here, so I measure bile acids regularly. But what we see is that it is a wide variation of what those levels are, okay? Even if babies with normal bilirubin, babies can have bile acids of 300 or bile acids of 10. And when they looked at this spread, they actually found a threshold of 40. Okay, so bile acids of 40. What does that mean? So that's the low bile acid group of less than 40 or a high bile acid group of greater than 40. And what I want you to focus on is the pink bars, because that's actually what's significant or what is most important. Everything else kind of was the same between groups. So children that had normal bilirubin, but also low bile acids, went to Kasai earlier, right? So this is consistent with what I was telling you. They went to Kasai at day 57 instead of day 69 on average. And this is CEPH, is portal hypertension. That is like the varices I spoke about. And there was fewer patients if you had lower bile acids that actually had any signs of portal hypertension. Their labs were better. The bilirubin was both normal for both groups, but AST, ALT, GGT, and albumin, things that we follow, were all lower in the albumin group. And again, the total bile acids were lower. Spleen size was more normal. Platelet count was more normal, all in the lower bile acid group. And when we talk about spleen size again, ascites, GI bleeding, portal hypertension, and transplant were all better in the babies that had less levels of lower levels of bile acids. And this is just showing this in a graphical form, that in the blue group are the babies at 6 months with, again, normal bilirubin, but also low bile acids. So they could avoid portal hypertension and even avoid transplant over years. So now, if what I'm telling you, that bile acids are really important to see if biliary atresia is going to progress, how do we target them? And this is kind of what's really exciting about the field of biliary atresia right now, is that I wanted to tell you first about kind of what, in order for me to tell you what the medicine is and how we target bile acids, I just wanted to show you a quick cartoon of what normal is, right? So bile acids are made in the liver, stored in the gallbladder, or if you're a Kasai baby, you don't have a gallbladder, so you'll just put that into the intestine, right? The liver is smart enough that it doesn't want to make those bile acids every day, so it actually recirculates or recycles 95% of your bile acid pool every day, and it only makes 5% new. So what happens is it gets made in the liver, it gets excreted in the intestine, and then it goes through the intestine, lets you absorb fats, absorb vitamins, and then in the last part of the ileum or the small intestine, it gets reabsorbed. So it goes reabsorbed through the vessels and gets brought back to the liver. So because it goes from the intestine to the liver, this is called entero, which is intestine, hepatic, liver, circulation of bile acids. Okay, so why I titled this, learning from different other cholestatic diseases, is because in 2 other diseases called Alagille syndrome and PFIC, which is progressive familial intrahepatic cholestasis, and both of these are genetic diseases. But what happens is these children are extremely itchy and they have high bilirubin. They also need transplant. And so what we did, probably actually 25 years ago now, is to say, you know what, these bile acids seem so bad. They're so high in these children. How can we decrease that pool of bile acids in the patient? And so actually a famous liver doctor who I was lucky enough to work with in Lurie Children's way back when, Peter Whittington, he said, you know what, let's divert some of these bile acids. There's too many in the body, and this is causing liver injury. Let's actually take a loop of intestine and connect it to this gallbladder, because these babies, these children with these other genetic diseases have a gallbladder, and actually let's let the bile drain out into a bag, like an ostomy. There's also, we've since been able to do an internal surgery where you can actually divert it away from the last part of the small intestine so it doesn't get uptake. So we call this a surgical diversion. We divert the bile acids so that it can get recycled. And so instead of a pool of 300, the diversion will have a pool of 100, okay? So that's called a surgical diversion. Many children we take care of have had this, and it works. It decreases the bile acids. It decreases the itching for sure. And there's some evidence to show that it actually decreases the fibrosis or the scarring of the liver, although that is not uniform because studies are small here. So the emerging FDA-approved exciting thing about liver now is that these two companies have made a medicine to say, you know what, instead of having babies or children, teenagers, adults undergo a surgery and have this bag sticking out of their body where bile is coming out, let's try this medically. So they developed a medicine that actually says, okay, you know what, we can target this medicine so it stops and it blocks the recycling in that last part of the small intestine where these bile acids get taken up again. And this has gone through phase 1, phase 2, phase 3 studies, clinical trials, and now just in the end part of 2021, I think just summer of 2021, it was approved. And there are FDA approved, meaning this medicine is safe and it's effective for PFIC and Alagille syndrome. And really what it does is a medical diversion. So no longer do we need this surgery. Phase 3 clinical trials for biliary atresia are going on right now. So how could IBAT, so this is called ileal bile acid transporter. So that's those channels that reabsorb the bile acids, and we want to block those. So those are called IBAT inhibitors. But how can that potentially stop liver injury in biliary atresia? So this is a normal liver, right? So these little tiny green dots are the bile acids. They go into the intestine, they travel through the intestine, and then they get reabsorbed. That's normal liver physiology, okay, that I just showed you. In biliary atresia, before surgery, so at diagnosis, and remember, I told you, even with normal bilirubin after surgery, these bile acids are still very high, right? But that in the babies that haven't even had a Kasai yet, and you can see that these are scarred down bile ducts, right? So you don't have bile flow. All of these bile acids accumulate into the liver. And then when they're stuck in the liver gets leaky because it's so injured. And the bile acids seep into the circulation. And that's what causes jaundice. It causes terrible itchiness. And this is what a biliary atresia liver looks like. But after surgery, you have your Kasai procedure, right? And now you have bile acids going into the intestine. You have less spillover, less bile acids that are accumulating in the liver so that you would have less injury to that. But the idea is that, and we don't know this yet, but this is what we're testing, is that, okay, let's see if we can then look at the liver here. See how it's still kind of grayish and greenish? If we can block those bile acids from coming back to that liver and decrease that pool, then we can decrease injury to the liver. And then what happens is, since you don't uptake that to go back to the liver, you just poop them out, is essentially what happens. And that's what we're testing in biliary atresia right now. So I quickly mentioned the Alagille and the PFIC, but I wanted to just do a quick review of what is phase 1, phase 2, phase 3, like what does that look like for now biliary atresia families as we're still studying this, and this is not FDA approved for biliary atresia. So we have preclinical or lab studies, and you know, as Casey mentioned, I see patients, but I also have a lab that we do things like looking at what causes biliary atresia, things like that. But that's the first step. Then we say, okay, we found this great medicine. We think it may be great. Let's take a small amount of patients, and that's called phase 1. And all we're looking at to see if that's safe. Is it safe in just a few patients? Then they say, yep, looks safe, but it's only in a few patients. So now that's not enough for us to, you know, start to treat patients, all patients with that. So phase 2 increases that number and looks at safety, but also looks at dosing. Do we have the right dosing? That's a phase 2 study. And it'll also show effectiveness. Is it safe? And what are the side effects? And is it effective? Once you pass phase 2 and you're like, wow, this looks really good, now it's time to go to phase 3. Phase 3 has a bigger number of patients, but, we don't, as clinicians, of course, I'm going to want to offer, a new medicine to my patients. And so I will be biased. I'm going to say, oh, wow, you know what? I think the itching looks better. This, this scar tissue looks better. The labs look a little bit better. I think this medicine's working. It doesn't really fly. You need something that's very rigorous, and you would want that for your children, really. So that's a placebo-controlled phase 3 study, meaning we have one group that doesn't get drug and another group that does, and those numbers are bigger. And then we also are vigilant at looking at safety and effectiveness, okay? And we can tell, and it's blinded, meaning I don't know whether your child's getting placebo or the real drug. The nurses don't know, the company doesn't know, the pharmacist that gives it out doesn't know, everybody doesn't know. And then only after the study's done do we unblind, okay? And then you present it to the FDA and say, look, I've tried it in phase 1, phase 2, phase 3. It's safe. That's what they care about the most. And it's effective. And then you get FDA approval. And then the company after FDA approval, they still look at safety and efficacy still. So it's a very rigorous process. I wanted to just go over the clinical trials in biliary atresia, both past and present, because there's just not that many, unfortunately. So way back in the 2000s and the 2010s, we tried prednisone, steroids, immune modulating IVIG, it's called, and none of that worked. So that is not standard. That does not show that it helps prevent biliary atresia from progressing. And now really the main phase 2 and 3 studies are really this odevixibat and maralixibat, where this odevixibat study had 70 centers, right? 7 centers in this other one. You really want to make sure that there's a lot of different patients involved in this so that you know that it's not only 3 patients that they're making this decision on, okay? So, but what we see here is if you took this list of clinical trials for biliary atresia and you compared it to clinical trials in high blood pressure, it would be, this is like can fit on only like a quarter of a page. Blood pressure would be like probably 80 pages long in terms of the clinical trials, right? So we really are, we don't have a lot of clinical trials going on right now. So my last 2 slides are really to say that as patients, advocates, caregivers in rare disease, and as by definition, a pediatric hepatologist, we care for patients that have rare disease. I think it's amazing that you guys are taking the time out to kind of be a part of this Biliary Atresia Family Foundation. And your role is really so important in terms of being advocates, educators, community builders. The FDA through that process will also have patient families come and tell them about their experience with the disease. Being participants in these clinical trials are really critical, because if you are not going to be able to, if we don't get enough patients to enroll, then there's no study, right? And we'll never get that information that we really need. And also being involved in research, meaning helping kind of being parts of these and bringing to the American Liver Foundation and physicians to say, this is what I'm seeing. My child is mostly affected by this. Can we study this? Can you tell me why this is happening? Bringing really good questions to the table, I think, is so helpful. And you guys are really the ones living it from the day to day. And that's the feedback that we need. So just to wrap this up, I think that, the pediatrician, again, is so essential for detecting this first when babies are young. We absolutely need to recognize biliary atresia, diagnose it, and treat it as early as possible. With Kasai and liver transplant, most children with BA all survive into adulthood, and it's really, so gratifying to see. But, and it's a caveat, is that, we still see that there is progressive liver injury, and that we have to manage long-term complications even in liver transplant. But now our field, I think is really focused. We prioritize biliary atresia because it is so important. And, we are making advances in genetics, trying to find more biomarkers or, markers in the blood that will help us decide whether it's biliary atresia or not, and novel therapeutics. But what I would say is that collaborations between bench research or lab research, clinicians and families are so critical in trying to help us make progress in this disease. So thank you again to the American Liver Foundation and to all the attendees. And really, this is part of our team at Mount Sinai, our liver team, and this is where I'm calling in from in New York. So I'll stop sharing.
Well, thank you very much, Doctor.
Thank you, Dr. Chu.
Oh, Ivory's here. Okay.
Yes, I'm here a little, Warren, but Warren is my backup. I apologize. Hopefully everyone was able to get a lot of information from Dr. Chu, who did a phenomenal job, Dr. Chu. I learned a lot this evening. If anyone has any issues hearing me, please raise your hand and let me know. The way we like to do this program tonight is to make it open, make people feel comfortable. You can raise your hand. If you have any questions, you can turn your camera on or off, however you feel comfortable with this. A couple of questions that we had, one from Richard, Dr. Chu. Are you using MMP7? What is your experience?
Okay, so great question. MMP7 for the audience is a part of, remember I told you about fibrosis and scar tissue. So it's a part of that process. And this has been really led by the group in Cincinnati to show that maybe can we use a biomarker to identify babies with biliary atresia earlier. I would say that, we use that sometimes, but not every time. And I don't think it's been adopted by everybody because not every center will run MMP7 in a time frame that's quick enough. So if we're going to send it out or it takes 3 days to run, those are potentially 3 critical days that we would actually rather get our liver biopsy done, do, and then get going and know. So we don't use it all the time and probably in selected times. And they haven't shown yet whether they know that around 1 to 2 months, it's a good marker, but really we want to know at 2 weeks, is that a good marker? At 1 week, is it a good marker? So we don't really have that data yet.
That was a great question. Thank you. Lincoln has a question.
Hi, I'm Lincoln. This is my daughter, Natalie. We had our Kasai at 30 days and she received her liver transplant at 7 months. Thank you for having this. This is really great and really informative. My question, I don't know if this is the right forum, and sorry if this isn't, but I was curious about what type of resources it would take to, I guess, figure out the cause of biliary atresia. And do you think that we're going to be able to figure that out in our lifetimes?
Okay, so that is a great question. And that's really that is right. What is causing biliary atresia? Why is your daughter needing a liver transplant so early, right? So my educated answer to here from all that we know is that I actually think that biliary atresia is a wide spectrum. It's kind of saying like you have pneumonia, but you don't really know what's causing it. And there's many different things that can cause pneumonia, right? So you can look at a spectrum, like I said, where babies have spleen changes and vascular and intestinal malformations and things like that with the biliary atresia. And then you have babies that just have the liver stuff, right? So those diseases may be very different, but we just lump it in because the bile ducts are similarly affected, right? And so, yes, I am optimistic, mostly because I'm a scientist and a physician, but I do think that actually in your lifetime, for sure, because the key to that, in my opinion, is actually looking on so I don't know if you guys have heard of precision medicine. Every patient, especially with rare disease, may be different. So right now we have the capability of doing genetics. And so genetics is looking at DNA, but that DNA then gets looked at to RNA and protein and metabolites really, right? So now, and we do this in the lab, but we can do this on the patient level too, is to actually profile all of those things and in a fairly quick manner, but not in this time frame where we would never. Right now, it's not at the fact where we can avoid Kasai, right? But in an ideal world, and I do believe that we are going to be there soon, what we would do is we would get the diagnosis of biliary atresia and literally send for all of that. As soon as we know, we would just profile your baby and then get that in a few hours and say, okay, this is the type of, because what we know is we've done a little bit of this already. And we find that some biliary atresia is more inflammation, some is more fibrosis or scarring, and some is a combination of both. But maybe in those babies with the more inflammation and less scarring, we can actually target that with immunosuppression or steroids or things, and they would be more like, we could then have them have better outcomes because we can tailor that treatment, right? So that's kind of where we're getting. I do think that we will be there. And we're gonna, the momentum has been really great with sequencing and doing these things, like, and really the time to do that has been so much shortened. So that's the long answer to yes, I think in our lifetimes for sure we will get to the back, but it'll take precision medicine to do it.
Thank you for asking. Lincoln, did you have a follow-up? Thank you for asking, and she's absolutely beautiful.
I know, she looks great.
Thank you. And thank you all for, dedicating your lives to helping families like us. Yeah, we really appreciate it and are thankful every day.
Brittany, we have a lot of questions, a lot of hands raised. Brittany.
Hi.
Hi, we can hear you.
Okay, awesome. My daughter was diagnosed with biliary atresia at 8 weeks, and she was jaundiced at birth. She was jaundiced at birth, and I was wondering, is there a connection between babies who are jaundiced at birth and who were later diagnosed with biliary atresia? She did photolight therapy, her bilirubin came down, we went home. So any insight on that?
Yeah, that is, it's, you guys are hitting on like the most important question. So actually in the last few years, so that gets to the question where I said, do we think biliary atresia is happening before birth, right? Like you said, she's jaundiced right at the get out, like how she's a day old, she's 5 days old and she's jaundiced. Did she already have biliary atresia? That must've been happening while I was pregnant, right? So so the answer is, if you asked me 10 years ago, we'd say, no, it's not actually. We think it's happening around 3 to 4 to 5 weeks. And that's why they only present really to us at 4 to 6 weeks. But the answer so there's been new information because when in a big state like Texas, what they did is they had 34 babies that were diagnosed with biliary atresia that had bilirubin levels. And when we say jaundice, we mean that it's the total bilirubin, but it's the liver component, the direct bilirubin that we really want to see. But they took all those 34 babies that had biliary atresia and they tracked back to see who had direct bilirubin levels at birth. And 34 out of 34 babies, all of them had elevated direct bilirubin at birth. That points us to say that actually, wow, that process is happening during pregnancy. The problem is it's like nearly impossible with all moms that are pregnant, right? How can we pick out those biliary atresia babies? And so we're studying a lot of different things, but so the answer is yes. I think that if your baby had direct bilirubin that it was high, probably it was happening during pregnancy, right? Nothing to your fault, but we need to figure out what is causing that, whether it's environmental, whether it's who knows, right? And so that is actually an excellent question because our thinking behind that has changed. But I want to be clear. So there's every baby that had biliary atresia had a high direct bilirubin, but not everybody with a high direct bilirubin go on to get biliary atresia. Okay, so that's an important distinction. But yeah, that's a great question. And so now it's our job to say, well, how do we study moms? Do we get 2nd and 3rd trimester ultrasounds? Could we potentially get to that, level where we maybe MRI or something that we can see the bile duct sooner? So it's a great question. Yeah. Thank you for that.
Thank you.
Thank you, Brittany. This isn't a question from Trisha, but we definitely wanted to highlight her. She mentioned her little boy just 8 days ago had the Kasai procedure. So just wanted to welcome Trisha to our group. You can definitely, if you want to come off, mention something, but I think in your post, you say you're just a parent. I don't know if that was a mistake to say, but you are not just a parent. Parents are superheroes. So you're definitely not just a parent, especially to that little boy. Our next question is from Brandy.
Hi. So,
Hi, Brandy.
Hi. We're actually near the hospital because my son just had to be hospitalized again, but hopefully not too long. But that's him. So he had his Kasai at 45 days and liver transplant at 9 months. Same as Brittany, his very first labs that they did, his direct bilirubin was at 0.75. And then by 4 days, it was up to about 2.75. So at first with his jaundice, I wasn't concerned because my daughter had also had jaundice at birth, and then it went away after, 2 weeks and everything. And their dad had the same thing. So we were just like, okay, so he's going to have jaundice and it's going to, go away. But thankfully his doctors and his pediatricians noticed right away, and they immediately asked for like both the direct and indirect to be run so that we noticed. But because his levels continued to fluctuate, so like his bilirubin would rise and then it would drop, and then it would rise and then it would drop. And some of his other things like GGT, ALT, AST, none of those ever actually changed too much, to where I know at first they kept thinking that they weren't even positive that it would be biliary atresia. And then suddenly they scheduled the Kasai for him, but they're like, we're not even sure he's going to need it. And then the week before, his bilirubin jumped like 3 points, and they're like, yeah, we're going to go ahead and do it. And then with his surgery, his surgeon said that his liver was slightly oversized and that his biliary tree wasn't in the place where they would normally attach the duodenum. So she had to basically like call an audible and move where she thought it might be able to work. So unfortunately, it didn't work all that well because it wasn't in the right place. So for babies like that, where it's like his liver apparently grew around his gallbladder and basically crushed it. But with things like that, where it's like the liver is a little bit weirder than what you would see, I guess, with other BA babies, like the surgeon said that she actually was kind of concerned about doing future Kasai procedures because of what she ran into with him and how nervous it made her. That like in those kinds of situations, like you were saying, it's something that probably was happening during pregnancy. He had several ultrasounds. Is that something that like would have been able to be seen, or like do we think is just unfortunately too difficult to see because of just the anatomy between where ultrasounds can go and how much they can actually see? That was a lot. I'm sorry.
No. I think you bring up really good points. And I think, so the answer to the last part of your question is really that right now we don't have, we are unable to diagnose biliary atresia in utero by ultrasound. Like that is, so we don't have that ability to get that fine detailed view of that, right? Maybe at some point. But what I think that's so interesting that's really hits home is that, you said at day 2, like day 2 of life, it was 0.7 and then it kind of went up and then went down. What would be great is if we had a marker like MMP7, that was brought up, or some other marker, say, you know what, at day 5 of life, this is biliary atresia. Then we can have done the surgery before that, right? Or but there's also risks, but to say, well, it's a 5-day-old that maybe weighs only 6 pounds, should we then, there's a higher risk to doing surgery then. But so that's where it's twofold. We're not at the point where we know how to diagnose it that early yet. But in utero, for your standard pregnancy ultrasounds, you cannot pick up biliary atresia. So there's nothing that was missed at that time.
All right, that's kind of what I was thinking. So I didn't think that would be a thing. I mean, he lucked out that he was born at like 10 pounds, so he was kind of above the scale. But because I actually have a friend who has a son with biliary atresia, so I had known about it beforehand. So that was the first thing that came to mind whenever they started talking about it.
So can I just bring up a thing that's because all of you are now so experienced with going through that process, you will have families that then reach out to you, right? That you said, like you said, I had a family with biliary atresia, so I went to them. The most important advice that I think you can give that's not medical, not overstepping anything, is to ask the physician to get a direct bilirubin. So that is the most important part of this whole process when babies are jaundiced. I think that you bring that up a good point, and people will come to you, and that I think is the most important thing.
Thank you.
Thank you so much. I just wanted to quickly thank Brittany for posting her email address for anyone on the call who would like to reach out to her and connect. So thank you so much. Everyone can check out her comment, i30brittany@gmail.com. And now we'll have Jennifer.
Was that for Jennifer Hagerman? I'm sorry.
Oh, there are two Jennifers. Jennifer iPhone.
I'm gonna guess that's me since I didn't sign in. I'm sorry. So I have a couple of questions, and please feel free to just answer the one that speaks out to you, because I don't want to take anyone's time. And the first one's more of an observation / question, because while I was in the hospital with my daughter, who's now 2 years old, I was, kind of given a negative prognosis because she was older than 8 weeks old at the time, and she had the splenic malformation syndrome version of biliary atresia. So I did a lot of research, and one of the things that struck out to me from the beginning was that I saw a clinical study produced by Japanese physicians, which was almost opposite in their statistics in terms of the success rate of Kasai's. A large part, I would imagine, is probably early diagnosis, because my understanding is between Japan and Singapore, they do put out to new mothers the poop colors, which if I had seen those, I would have known within week 1. But lo and behold, I didn't know that pale yellow was an indication. And the second is I know in Japan, they have higher rates of biliary atresia comparatively to their population. I think in the United States, it's like 1 per 15,000, and it's twice that rate in Japan. So maybe it's the experience of the surgeon. But I did have the opportunity, because it is a rare disease, and I am part of a biliary atresia support group, where one of the mothers, an American mother who was stationed over in Japan, so a Japanese facility performed the Kasai, and it was interesting to me that their post-surgical procedures were a little different. Like they had a thing, in the United States, it's standard practice to administer Ursidile and I can't remember, Bactrim, where they were doing something different. They were using an herbal thing called Inchin Coda, which I'd never heard of. And, when I try to do some research, because I'm always interested in knowing, what else is there out there. I'm not Japanese. I can't. So I think with the internet, it kind of much dies with the English language. But I also noticed that in my discussions with my GI locally where I'm from, which is Virginia, and we fly out because we, thank you all Bureau, they fly us out to Colorado, and I had the opportunity to interact with the pediatric GIs there and the hepatologists to get sort of a second opinion whenever I have a question. And one of the things that sort of stood out to me was, when I asked, what is the standard of practice and why is it? Because I can see in the biliary atresia forum, there doesn't seem to be any consensus. Like if, I had one GI who was like, well, you can, if she has no episode of cholangitis, she can take it, stop Bactrim at 1 year, another one that says 2 years. Same thing with Ursidile. Someone was like, well, if she doesn't have an episode of cholangitis after the first year, she can stop taking it after 1 year. But then standard practice of another facility was 3 years. And then the other question I was asking after one of the children in the biliary atresia support group passed because of varices bleeding, which really scared me because the mother had always posted the child's labs, and I looked at them like, wow, they're better than my daughter's. So how do I know? So I started looking at, prophylactic endoscopies, and I asked my GI. He seemed resistant on it, but I talked to the GI in Colorado, and she thought about it. She goes, well, given that your child's asplenic, maybe that is something you should pursue, because one of the first indications of portal hypertension is enlarged spleen. Your daughter doesn't have a spleen, etc. But I mean, it was just, it's amazing how with a rare disease, it's almost impossible to come to a consensus, because even though there doesn't seem to be unity, or there's, all this stuff that's happening separately. And, I'd love to know what's happening in Japan. What are they doing? Because I know they appear to have a higher rate of it. I know liver transplant is not religiously something they pursue. I feel like there's a knowledge block, or at least it's hard as a parent to get that knowledge. So that's one issue is, when we talk about standard of care, what is the standard care? Is there a standard of care? You can't Google this, you kind of have to rely on your pediatric GI to sort of keep you informed, and then hope that, it's backed with enough research. So that's my question / comment. And my sort of second post was, I've been doing a lot of, and this is probably more applicable, because I look at regenerative medicine, because I know that one aspect, I saw the study that that located like 3 different causes for potential causes for biliary atresia for the progression of fibrosis despite a successful Kasai, and small bile acids was one of them. But then they also mentioned that it's a continued your immune system is still causing it, that whatever caused that triggered the biliary atresia still continues because it doesn't, it's like I don't know what process it is. But I also thought, is there any ongoing, because I saw ongoing adult studies on using PRP or, or other like stem cell therapies, because if the liver is the most regenerative organ, why is it not able to regenerate after a successful Kasai? All right, end question.
Okay, so lots of questions in there, I would say, and somebody asked also, poop color is a hugely important thing. In Japan, that's where Kasai first started. So there is a higher prevalence of biliary atresia in Japan, in China, in Taiwan. Whether or not that's actually genetic based, or whether that's an environmental thing, something like that, clearly that is. There is a like 1 in 1,000 prevalence of in a small indigenous community in New Zealand. So there is something that it's certainly the prevalence changes in the United States because our population is so heterogeneous in terms of race, ethnicity, where you've immigrated from, things like that. We've looked at stool color cards, and it really hasn't become standard because it's just not going to pick up as many patients as when your prevalence of disease is so high, like in Asian countries. So that being said, you mentioned a couple of therapies that they use in Asian countries, and they've published different outcomes, but also whether they do get babies sooner, but also that biliary atresia may be a little bit different than the biliary atresia that we see in the United States. So I would just take that with a grain of salt. But I think we are all learning from each other across the world. And then let me just think, your comments on heterogeneity of approach, that is 100% true. The only thing I'll say is that we actually just did a recent study, we meaning the liver community, about who gives antibiotics, who does what kind of surgery, and it is very different. So, there are better outcomes in countries like France where their healthcare is centralized and that the same surgeon is doing all of the biliary atresias for half the country. That actually, because experience matters. So I would say that for those families that come to you with, they're considering biliary atresia, really, honestly, if it were my own kid, I would make sure that I am at a center that sees a lot of biliary atresia. Okay, so it's 7:03, but I still have a few more minutes before my sons knock down my door. But
thank you so much, Dr. Chu. We'll take our last question from Nicole. She has her hand raised.
Hi, I'm Nicole, and this is Evelyn right over here. She is 3 months old, and she was diagnosed with biliary atresia at 2 weeks old. We had her Kasai at 6. So we're still waiting to kind of determine if her Kasai is going to be, quote, successful or not. She started presenting, she was born jaundice and had white stools at 5 days. So fortunately, our pediatrician was familiar with the disease and immediately got a direct bili on her, and it was elevated. So one of my questions is, how come testing for direct bilirubin isn't always a standard practice across the board? My nephew was just born and he was jaundiced, so having experience with her, they immediately asked, the pediatrician to check his direct. So that was not something that they did. So why aren't we checking for direct? And then also, since she presented so early, she was having the white stools at 5 days. Her GI doctor now has kind of indicated that because of the early presentation, meaning we had some issues going on in birth, it's less likely for her Kasai to be successful. Have you seen statistics or information for that statement to be true, that early symptoms mean a Kasai is less likely to be successful?
Okay, so great questions. The answer to the last part is no. Earlier symptoms is not necessarily less likely that your Kasai will be successful. And the key question that you asked also is, why don't they check direct bilirubin on all these babies? Like we just talked about. Remember, I said, if someone's gonna ask you, you should say, check the direct bilirubin. So the prevalence, and this all becomes cost, right? What is cost effective? What is possible to run on the millions of babies that are born in the United States? And because our prevalence isn't so high, like in Taiwan or in, actually Argentina, it's not cost effective for every baby born to get a direct bilirubin, because actually it takes blood, right, to get direct bilirubin, whereas they'll do like a transcutaneous bilirubin, and they just do it through the skin to measure the total bilirubin, and that's very fast. You don't have to poke the baby. On the other hand, parents may be like, wow, this is a disease that affects 1 in 12,000 kids. Don't poke my baby. I don't want the blood to be drawn. The baby's just a day old. I'm taking my baby home. So for so many of those reasons, it just is not, it's not that frequent enough. But what we are doing, and to address that, is trying to create techniques that are less invasive, maybe looking at the blood spot that gets drawn on all babies to do newborn screening, to try and measure direct bilirubin. Is there a better way? Could we even potentially measure it in the skin at some point? How can we do that on every baby to know and be able to pick up those babies with high direct bilirubin at birth? And like I said, it does not mean that you will have biliary atresia, because there's a whole list of other problems that may resolve even, right? But at least to catch yourself on the radar of the liver doctor to say, I'm going to make sure I follow the baby. The family knows they need to follow up, and we don't miss it, and we catch it at 2 weeks, right? So that's so critical. And this is why it's so important for families to bring up these questions, because you've already gone through the process and you say, I wish I had known that. Those questions are so important. So you should tell us those questions, right? Because yes, we know that, or we're like, yes, you're right. We are not doing a good job of that. How can we make that better? 100%. That's a great question.
Great. Thank you so much.
Thank you so much, Dr. Chu, for this incredible program. You were so helpful with all of the answers and information that you provided, and everyone for joining us this night. We could not have asked for a better group of people, and we hope that you are all members of our Biliary Atresia Facebook group and connect with one another. Like Brittany gave her email address, please connect with one another. The Facebook group, we want it to be a support for all of you and your families. So again, thank you, Dr. Chu, for giving us your time today. We could not have had such a great program without you. I'm just going to quickly, if anyone has additional questions after today's presentation, please continue this conversation in the Facebook group. If you have specific questions regarding this topic and Dr. Chu, please send them to me at iallison@liverfoundation.org, and we can work on getting those answered for you. For questions about liver wellness and disease, or for emotional support, please contact our helpline at 1-800-GO-LIVER. That's 1-800-GO-LIVER. And I also have just put it in the chat, the phone number, so you guys can take that, as well as our online chat. The great thing about that, our chat is our online call helpline is available Monday through Friday, 9 a.m. to 5 p.m. Eastern. So you can actually speak to someone if you have any questions or comments. We have a couple upcoming events. We're excited to announce that our 2023 Liver Life Walk event season starts this weekend in Arizona. This year, we will host walks across the country in states including California, Georgia, Massachusetts, New York, and New Jersey, to name a few. For a complete listing of all the states we will be hosting events in this year, or to register for the Arizona Walk, please go to liverlifewalk.org. We hope to see you on the walk trail. And on March 15th and 16th, we are hosting our first autoimmune liver forum, where we will bring together 75 to 100 autoimmune liver disease stakeholders, patients, caregivers, hepatologists, primary care providers, patient advocacy organizations, for a virtual forum to identify solutions for improving the health outcomes of individuals with PBC, PSC, and autoimmune hepatitis. And that includes having a couple of medical professionals regarding pediatric autoimmune liver disease. So that is our program this evening. Again, we'd like to thank Dr. Chu and all of you for joining us this evening. Thank you all so much.
Have a great night, everyone.